In this session, we'll be dealing with the gross anatomy of rectum and anal canal. So rectum is the lower dilated part of the large intestine. It is located in the pelvic cavity. So how it is different from large intestine? That it has no tinea colia, no saculations, no appendices epiploicae, and there is no mesentery or mesocolon. So it begins at the third sacral vertebrae as a continuation of the sigmoid colon, and it ends at 2 to 3 centimeters in front and slightly below the level of tip of coccyx, where it continues as anal canal at anorectal junction. So anorectal junction in male corresponds with apex of prostate. Length is 12 centimeters. Breadth in upper part it is 4 centimeters. In the lower part it is dilated called ampulla. Curvatures. Anteroposterior curvatures are there, which are 2 in number. One is the sacral curvature, which is convex backwards, which corresponds with hollow of sacrum, and perineal curvature, which is convex forwards at anorectal junction. Puborectal sling of levator ani maintains the perineal curvature. So lateral curves, these are rudimentary saculations affecting sides of rectum. Along the concavity of these lateral curves, horizontal rectal valves project into the interior of the rectum. So upper curve is convex to the right. So it is at the junction of third and fourth sacral vertebrae. The middle curve, which is more prominent and convex to the left at sacrococcygeal junction, and the lower curve is convex to the right at tip of coccyx. You can see here, this is the sacral flexure and this is the perineal curvature. These are the anteroposterior curvatures, and this is the puborectal sling which maintains the perineal curvature. You can see here, these are the lateral curvatures. This is the upper right, this is the middle left, and this is the lower right. You can see exactly opposite of this curvature. In the concavities, you can see the valves. There are 4 Houston valves. These are the mucosal valves, 1, 2, 3, and 4. The third one is the most constant. You can see the rectum continuing as the anal canal. You can see here, this will be the pectinate line, this will be the Hilton's line. You can see this is the sphincter ani internus and this is the sphincter ani externus muscle. So this is the lateral ligament of rectum consisting of the middle rectal vessels. So these are the Houston's valves. The most constant of this is the third valve. Then if we come to the relations, first we will deal with the peritoneal relations of rectum. The posterior surface is non-peritoneal. Anterior surface is covered with peritoneum in upper 2/3. In upper 1/3, peritoneum is covering the front and sides of the rectum. In middle 1/3, peritoneum covers only the front. In males, the peritoneum reflects from rectum to the urinary bladder as rectovesical pouch, whose lowermost part is 7.5 cm above the anus. In females, from the rectum, peritoneum reflects onto the posterior wall of the vagina, forming pouch of Douglas. So the lowermost part of pouch of Douglas is 5.5 cm above the anus and 7.5 cm above the external orifice of the vagina. On each side, the peritoneum reflects from upper 1/3 of rectum onto the lateral pelvic wall, forming pararectal fossa. So relations in front. The peritoneal covered upper part is related to sigmoid colon and small intestine. The non-peritoneal lower part is the rectal ampulla. So in male, it is related to base of urinary bladder separated by seminal vesicles, vas deferens, and posterior surface of the prostate. So both structures are separated from rectum by rectovesical fascia of Denonvillers, which is derived from the primitive rectovesical pouch of peritoneum. So in the female, it is related to middle 2/4 of the posterior vaginal wall separated by ill-defined rectovaginal fascia. So you can see here in the male, the peritoneum is reflecting onto the bladder as rectovesical pouch, and here you can see the rectovesical fascia, and here you can see the fascia of Walders's. So in female, you can see the peritoneum is reflecting onto the posterior wall of vagina and to the uterus, forming the pouch of Douglas. So this is the rectal ampulla, the dilated part of the rectum. This will be the anorectal junction. This is the perineal body. Posterior relations of the rectum. So if you see in the midline, it is related to third, fourth, fifth sacral vertebrae and coccyx, anococcygeal raphe, ganglion impar, median sacral vessels, superior rectal artery opposite S3, fascia of Walder, which extends from anorectal junction to coccyx, formed by thickening of pelvic fascia. On each side of midline, piriformis muscle, coccygeus muscle, levator ani muscle, mostly of the left side, sympathetic trunks, lower part of sacral plexus, pelvic splanchnic nerves, lower lateral sacral vessels, and lateral division of the superior rectal artery. You can see here, these are the sympathetic trunks. So this is the superior rectal vessel, this is the median sacral vessel. Here you can see the piriformis muscle, here you can see the coccygeus muscle, here you can see the levator ani muscle, here you can see the ganglion impar. can see the lateral sacral vessels. You can see the sacral plexus of nerves, and you can see the pelvic splanchnic nerves. These are all the posterior relations, and you can see the sacral vertebrae behind. Lateral relations of rectum: upper one third pararectal fossa containing sigmoid colon and small intestine, middle one third pelvirectal space which is having fat and lateral ligament of rectum conveying middle rectal vessels and levator and muscles, lower one third ischiorrectal fossa and their contents. You can see here this is the pelvirectal space and this is the ischiorrectal fossa. So interior of the rectum, there are temporary folds which are longitudinal seen in lower part and disappears in distinction, and there are permanent folds which are most important. These are horizontal in direction, semilunar in shape, formed by duplication of the mucous membrane with underlying connective tissue. These are the Hostan's valves located along concavities of the lateral curves of the rectum. So if you see the first valve, so it can be originating from right or left, located at rectosigmoid junction at S3 vertebrae. So distance from anal orifice is 12 to 14 centimeters. If you see the second wall, so it is from the left wall along concavity of the upper lateral curve, and it is approximately 2.5 centimeters above the third wall and 7.7 centimeters above the anal orifice. So third wall, which is the most constant, it arises from anterior and right wall of rectum along the concavity of the middle lateral curve. The circular muscle of the valve is the Nelaton sphincter, is also called as Nelaton sphincter. So it is opposite S5, just above the ampulla of the rectum, divides interior into upper pre-allantic part of the hindgut and lower parts post-allantic part of the cloaca, which are different in development. So it is approximately 5 centimeters above the anal orifice. Then the fourth one is the arising from the left wall of rectum along lower lateral curve. So 2.5 centimeters below the third wall, and it is 2.5 centimeters above the anal orifice. So cannulation of the rectal, cannulation for rectal washing is passed in left rectal position to avoid injury to the third wall. So arterial supply of rectum and anal canal. So these are the arteries which supply. Superior rectal artery, it is a branch from inferior mesenteric artery, it supplies up to pectinate line. Middle rectal arteries, which arise from anterior division of interiliac artery, supplies the lower part of rectum. Inferior rectal arteries, which are branches of internal pudendal artery, so they supply the perianal skin, sphincter ani muscles, anastomosis at pectinate line with the superior rectal artery. So in addition, it also receives from median sacral artery, inferior gluteal artery, and internal pudendal arteries. So you can see here, this is the superior rectal artery, this is the internal iliac artery, which is giving rise to middle rectal artery, and here you can see the inferior rectal artery arising from internal pudendal artery. Venous drainage of rectum and anal canal. The plexus, they form the annulus hemorrhoidalis, encircles lower part of rectum and anal canal. So they have internal and external sets. Internal plexus surrounds anal canal above Hilton's line. They lie between mucous membrane and sphincter ani internus muscle. Continues above with radicals of superior rectal vein. Below continues with external plexus by piercing anal intermuscular septum. So external plexus, they surround anus between perianal skin and subcutaneous part of the external anal sphincter muscle. Continues lateral with inferior rectal vein. So upper part, that is above the pectinate line, there will be 6 veins joining to form superior rectal vein, drains into inferior mesenteric vein, portal system. Middle rectal vein drains into internal iliac vein, systemic vein. Inferior rectal vein drains into internal pudendal vein, again systemic vein. So these are the sites of portocaval anastomosis. Radicals of the superior rectal vein are valvulous and surrounded by loose aerial tissue. Increased portal pressure results in distension. So trunk of the superior rectal vein pierces posterior wall of rectum. So prolonged straining in constipation, the radicals of this superior rectal vein will be dilated, resulting in hemorrhoids. You can see here superior rectal vein. These are the radicals of superior rectal vein within the anal columns. You can see the internal iliac vein. You can see the middle rectal vein, and here you can see the internal pudendal vein and inferior rectal vein. Here you can see the external rectal venous plexus. Here you can see the internal rectal venous plexus between sphincter ani internus and the mucous membrane. So this is sphincter ani externus, this is sphincter ani internus. You can see a conjoined sheet formed by the levator ani and longitudinal muscle coat of rectum separating the sphincter ani externus and internus muscles. These relations are important because when we describe the sphincter ani internus, you need to remember these relations. So between the perianal skin and sphincter ani externus subcutaneous part, there are external rectal venous plexus, and here between the sphincter ani internus and mucous membrane, there are internal rectal venous plexus. So this is the pectinate line where there is portocaval anastomosis. This is the caval system, this is the portal system. So primary internal piles are hemorrhoids. Their location is like this. Anal columns in the given positions distant earlier than others in the portal hypertension. The left lateral 3 o'clock position, right posterior 7 o'clock position, and right anterior 11 o'clock position. So this is the left lateral, right posterior, and right anterior. These are the three positions of the anal columns of the rectal vein radicals, superior rectal vein radicals, which dilate earlier than the other sides. So lymphatic drainage of rectum and anal canal. They are divided into intramural plexus and extramural plexus. Intramural plexus, they are located in submucous and intramuscular plexus, and communicates with extramural plexus by piercing rectal wall. Extramural plexus, the upper part accompanies superior rectal artery and they drain into left common iliac nodes and pararectal nodes. The middle part accompany middle rectal artery and drain into internal iliac nodes, and the lower part drains into internal iliac nodes. Anal canal below pectinate line will drain into horizontal group of superficial inguinal nodes. You can see here from the upper part common iliac nodes, from the middle part into the internal iliac nodes, and you can also see few pararectal nodes interfering with the upper part, and even the lower part goes to the internal iliac nodes, and below the pectinate line you can see it is going to superficial inguinal lymph nodes. So nerve supply, sympathetic is from superior epigastric plexus, L1 L2 segments, mainly vasomotor, stimulate internal sphincter, inhibit rest of the musculature of rectum. Parasympathetic is from pelvic splenic nerves, S2 S3 S4 segments, secretomotor to the gland, stimulates peristalsis and relaxes the sphincters. So supports of the rectum, puborectal sling of levator ani maintains anorectal flexure as I have shown in the earlier diagram. So few fibers of the levator ani attached to anal canal after passing between external and internal anal sphincters. Reflection of pelvic fascia from parietal to visceral layers around the rectum. Facial sheet of Waldeyer and lateral ligament of rectum derived from the pelvic fascia also acts as support. Pelvirectal fat and ischiorrectal fat also supports the rectum. So this is the barium enema showing the rectum, sigmoid colon, and the large intestine. Anal canal extends from anorectal junction, which is located 2 to 3 centimeters in front and slightly below the level of tip of coccyx, to the anal orifice, located 4 centimeters below and in front of tip of coccyx. Anterior wall of the canal is shorter than the posterior wall, surrounded by sphincter ani muscles, which keeps it closed except during defecation. Length is around 3.8 centimeters. Breadth, it presents as anteroposterior slit when empty. Relations intent, in male it is bulb of penis and spongy part of urethra. In female it is the lower part of the posterior wall of vagina. So behind it is anacoccygeal raphe and fibrofatty tissue between perianal skin and raphe. On each side ischiorectal fossa and its contents. You can see here, this is the anacoccygeal raphe. So between the anal canal and anacoccygeal raphe. Here if you see anteriorly, this prostatic part of urethra continues as membranous part of urethra, and which will continue as the spongy part of urethra in the bulb of the penis. So that forms the anterior relation in male. So here you can see the lowest part of the vagina forms the anterior relation in case of female. This is the lower part of the vagina which forms the anterior relation in case of female. So you can see on either side there is ischiorectal fossa forming the relation for the anal canal. So interior of the anal canal, as you see here, this is the pectinate line, this is the Hilton's line. We will be concentrating with the following parts, so which will help us. You can see here, interior of the anal canal is divided into upper part, intermediate part, and lower part. So upper part and intermediate part are separated by the pectinate line, and the lower part and intermediate part are separated by the Hilton's line, which represents the anal intersphincteric groove or lower part of the internal sphincter. So pectinate line and Hilton's line divide interior of anal canal into upper part. So above pectinate line, which is 15 millimeter in length, lined by semi-transparent mucous membrane. Internal rectal venous plexus lie outside mucous membrane and makes the appearance plum red in living. So it has anal columns of Morgagni, which contains radicals of superior rectal vein. These are longitudinal permanent folds, 6 to 10 in number. So distended columns above pectinate line form the internal hemorrhoids. Bright red bleeding is a classical clinical symptom within the stools, and sometimes these internal hemorrhoids will prolapse outside and get strangulated. So below pectinate line, external hemorrhoids and are very painful due to thrombosis or rupture of veins. So anal valves, also called as valves of Ball. So these are crescentic mucous folds connecting lower ends of columns. So position of the valves represents the pectinate line or dentate line. So these valves above lined by simple columnar epithelium, below lined by stratified epithelium. So a tag formed by rupture of anal valve is called sentinel pile. So anal papillae, these are the epithelial processes projecting from free margin of anal walls. They represent the remnant of anal membrane which has ruptured to open the anal canal. So anal sinuses, these are the recesses above the anal walls between anal columns. So they are deep in posterior wall of the anal canal. Anal sinuses are deep in posterior wall of the anal canal. Anal glands, the sinuses receive ducts of tubular anal glands which ramify in submucous coat and sometimes pierce internal anal sphincter. So intermediate area, it is also called as area of pecten or transition zone, 15 mm between pectinate line and Hilton's line, lined by non-keratinized stratified squamous epithelium without sebaceous and sweat glands, surrounded by internal rectus venous plexus, bluish pink color in living, supplied by somatic spinal nerves. Lower area, also called as anal verge, 8 mm, lined by skin. Fibroelastic septa formed by fusion of longitudinal muscle of rectum and levator ani cause corrugations in the lower area. So this fibroelastic septa, we call it as corrugator cutis ani muscle. So these are the corrugations, the lower 8 mm anal verge. So this is the Hilton's line. So this is the pectinate line. These are the anal valves. This gap is the anal sinus. So this is the anal papillae. So pectinate line versus Hilton's line. Pectinate line represents the mucocutaneous junction. So whereas Hilton's line represents color contrast between bluish pink area above and the black skin below. It corresponds with the position of anal walls. Situated at middle of the internal sphincter muscle, represents anal intersphincter groove at lower end of intersphincteral muscle. So lower end of internal sphincter muscle is the Hilton's line, whereas middle of the internal sphincter muscle is the pectinate line. Separates the developmentally different parts of the anal canal. So anal intermuscular septum is attached carrying fibers of levator and longitudinal muscle of the rectum at this level, Hilton's line. So nerve supply, blood supply and lymphatic drainage is different above and below the pectinate line. Ischiorectal abscess opens at or below the Hilton's line. The upper part above the pectinate line develops from endodermal cloaca, whereas lower part develops from ectodermal proctodeum. Then anal fascia and lunate fascia extend up to the level of Hilton's line. So these are the differences between pectinate line and Hilton's line. So now if you see the pectinate line, the upper area and lower area, how they are different. So upper area develops from endodermal cloaca, whereas lower area develops from ectodermal proctodeum. Upper area supplied by superior rectal artery, lower area supplied by inferior rectal artery. So upper area drains into portal vein, lower area drains into systemic vein. The upper area drains into internal iliac nodes. So lower area drains into superficial inguinal nodes. That's why this pectinate line acts as watershed line. Upper area supplied by autonomic nerves, lower area supplied by the spinal nerves. So sphincter ani internus muscle, it's an involuntary muscle. It is a thickening of circular muscle of rectum, surrounds the upper 3/4 of anal canal. Lower end corresponds with the Hilton's line, middle part corresponds with the pectinate line. Internally, it is related to internal venous plexus. Externally, a conjoined sheath derived from levator ani and longitudinal muscles of rectum separates it from external sphincter. So this I have shown in the earlier diagram. I'll show you again. Here you can see internally related to internal venous plexus, externally separated by conjoined sheath derived from levator ani and longitudinal muscle of rectum, separated by sphincter ani externus, separated from sphincter ani externus. So nerve supply, superior epigastric plexus sympathetic and pelvic splanchnic nerves parasympathetic. This is involuntary. So sphincter ani externus, it is voluntary, surrounds the entire length of anal canal, 3 parts, subcutaneous part, which is flat band around anus, separated from skin by external venous plexus. I have shown in the diagram here. So this is the subcutaneous part, this is the superficial part, and this will be the deep part. Subcutaneous part separated from perianal skin by the external rectal venous plexus. The superficial part, elliptical, so origin from tip of coccyx and anococcygeal raphe, insertion to perineal body. You can see here from tip of coccyx and anococcygeal raphe, insertion to perineal body. So you can see the deep part, no bony attachment. So it encircles the upper part of the anal canal, then inserted to perineal body, continues with the transverse perineal superficial muscle of the opposite side. Annular in shape, surrounds anorectal junction, no bony attachment, inserted to perineal body, continues with opposite superficial transverse perineal muscle. Nerve supply, inferior rectal branch of the pudendal nerve and perineal branch of the fourth sacral nerve. You can see here. So few authors consider the sphincter ani external muscle like this, like the deep part is representative of the puborectal sling of levator ani, and the middle part or the superficial part, takes origin from tip of coccus through anacoccygeal ligament and inserted to perineal body, whereas subcutaneous part takes surrounds the anal orifice and gets inserted to perianal skin. Anorectal ring, it is a muscular ring at anorectal junction, upper part of the internal sphincter, deep part of the external sphincter, and puborectal part of the levator ani, all three contributes, and surgical incision produces the incontinence of feces. So anal fistula, these are the fibrous tracts connecting two surfaces, mainly the anorectal mucosa and the skin. Infected anal glands at intersphincter region, these are responsible for the formation of the anal fistulae. So abscess can spread in 5 directions: upwards, downwards, medial, lateral, and circumferentially. So it's a common type of fistula, extends down as perineal abscess at lower end of the internal sphincter, may spread to ischiorectal fossa through external anal sphincter muscle. Thank you.